We also will talk about another abdominal related condition, surgical condition, hernia, diverticulitis, large bowel obstruction. So we can spend so much time on one organ or one cavity as much as possible. So the abdominal cavity has a lot of surgically related issues, and some of them are what we are talking about at this time. So for hernia, to the layman, you have a weakened part and something from within moves into that weakened part, and it can be there and there's no cutoff of nutrients, or it can enter the weakened part into the pouch and there's a cutoff of nutrients or blood supply. Then it becomes strangulated hernia. We have what is covering the weakened portion that has protruded. We have the contents of the sac. And so where you have an experienced person, we talk about reduction of the hernia by trying to gently move back the contents of the sac into the original cavity. But then, if it's strangulated, it is only through surgery that you can help the patient. So we have reducible hernia, strangulated hernia, irreducible hernia, as I have just mentioned. And we have also types of hernia depending on the location. So we have hernia in the inguinal area, femoral hernia, umbilical hernia, incisional hernia from a cut end. We have hiatal hernia at the top of the stomach, towards the diaphragm area. And then we have other types of hernia, of inferior lumbar hernia, gluteal hernia, etc., etc. As you read and you get more, just add to your knowledge. So we can have hernia developing when you are chronically constipated. So those of you who do not empty your bowel regularly, why don't you empty your bowel? Anyway, you have to try and empty your bowel regularly, at least every day, so that you don't get hernia from me, I beg. Then, if you are always coughing, why are you coughing? Treat it so that you don't get hernia. And other things like heavy lifting. So if you are going to lift, please ask for help. Maintain the right body mechanics so you can enjoy this profession for more years than if you are sick. And there's those of us who are obese. I don't think I'm too obese, but if you think I'm obese, don't worry, I'll do something about it. So obese people are also at risk. We have to do something about your obesity. Poor nutrition, smoking, etc. So if you have hernia, you have pain, very severe pain, and you can be nauseated, you can vomit. There will be a protrusion at the affected part. So you come and we examine you. It's obvious, mostly it's obvious. So physical examination alone may diagnose, let's say, strangulated hernia or whatever hernia. Then you can do an X-ray also. So surgically, we do the herniorrhaphy or herniotomy, henioplasty, whatever. We do surgery to take the sac that is diseased off and then strengthen the weakened portion for you. So non-surgically, we give you some painkillers. Of course, every surgical patient is given an antibiotic cover to prevent infection of the wound, some drug to prevent constipation, and then we can give you something to wear to make sure that in future you don't come back with another hernia. So the pre-op and post-op care, because it's the same abdominal area, inguinal, whatever type of hernia, you prepare the patient adequately. Highlight the fact that after the surgery, incisional hernia can occur. So don't go home lifting as heavy things as you. Fortunately, hernia surgery is covered by health insurance. So the patients may have to always renew the insurance to make sure it's active. And then we continue with the. So I've added to your slides education on discharge, etc. I'm giving you highlights, okay? I'm giving you highlights. If you don't read your slides on Sakai, and you don't read extra information to add, your knowledge base will be copious. It will not be enough. So please, there's so much information on the slides. Read it to add to your information. So I found some picture on the umbilical hernia for a child. You see the sac, that's a herniated umbilicus. And this one is incisional hernia. After the surgery, here, the lower, it's a woman, I think maybe a cesarean surgery, and look at what has happened. So if you are a surgical patient, you have to handle yourself well. Handle yourself. Don't stress yourself too much. You don't tie up yourself too much. You don't lift things that you think that is too much. You don't do that to yourself, because you can have herniations. All right, so we now also turn our attention to the diverticulitis, which is part of a large intestine problem. So the diverticular, you see, the normal large intestine is this one. Then you have parts of it projecting, okay? And so this diverticular can become infected, and we call it diverticulitis. And we are supposed to remove them. You see the way it is. This is a diverticular. It's not supposed to be like that. You see, it's not supposed to be like that. So when it becomes infected, then we try to take that part that is disease away, and we anastomose with the healthy one. For most of the intestine-related surgeries, we take off the disease parts and we join the healthy portions together. Okay. So some of the causes could be weak intestinal wall, chronic constipation. You see constipation surfacing everywhere. Don't be constipated though. If you are constipated, do something about it. Don't be happy if for 3 days you have not gone to the washroom. So there are some clinical features where you have some vomiting, nausea, fever, chills, because there's an infection, and then I put in some complications and investigation, etc. But how do we manage this condition? We ensure that whoever is affected takes bed rest and high fiber diet so that you will not be constipated. Intravenous fluid, antibiotics to treat the infection. I told you that the diverticular is not a problem. When it becomes infected, that is when the problems will start. So we want to treat the infection, and then we give you appointment for the surgery, and then the surgery is done. So usually we do resection and anastomosis as much as possible. Sometimes when it's very, very bad, they may decide that they will do a temporary colostomy. So the stool comes out on your abdominal wall, okay, before they do the corrective surgery. But most of the time, colostomy care is really difficult. But if it's a child or whoever is affected, the physiological state cannot withstand major surgery, then they will do the colostomy as a temporary measure. When they correct the problem, then they close up the stool outlet on the abdominal wall. So once again, because this is, what is it called? An abdominal surgery, the pre and post-op care is almost similar. In the same way, when you have large bowel obstruction, a large bowel obstruction can be volvulus, can be diverticulitis, or can be intussusception. Unfortunately, this day we have discuss these three, and so I think that we can comfortably end here for this session, and I urge you again to read the slides on Sakai. So thank you very much for listening to these sessions on your video.